Hello, everyone. I hope you're all well. I'm Himanshu Burse, one of the obstetric consultants in the UK. Welcome to our channel. If you like, please do subscribe our channel and ask others to do so. And if you have any specific topics you want to be covered, please put in comment section and we'll make a video about the same. Today we are going to talk about obstetric history taking. Now, the importance of history, it is basic requirement for any medical consultation. It's hugely important because you can build a rapport with the patient, you identify risk factors, and it allows you planning for proper investigations and management. So in obstetric history, name, again, as we discussed in another video, that it's very important to refer patient by their name. You can always ask the patient how they like to be called with their name or surname, and that helps them to make feel comfortable with you talking about their problems. Date of birth tells you about their age, and certain age groups carry a high risk for obstetrics. Demographics as to where they live, as certain issues are common in particular demographic, as well as it will allow you to arrange their follow-up appointments based on their distance from your clinic. Height, weight, and BMI tells you if they're underweight, normal BMI, or overweight, because that has got bearing on their obstetric management. You'll always check if it's their first pregnancy or more than once they had been pregnant before. Gravidity always denotes current status along with any pregnancies conceived, irrespective of the outcome in the past. Meaning, if somebody is not pregnant at that point in time, you will not mention gravidity. If they are pregnant for the first time, they will be referred as primigravida. If they had one delivery and a miscarriage in the past, and they're pregnant for the third time, so you will refer to them as G3P1 plus 1, meaning this is their third pregnancy. Previously, they had one delivery and a miscarriage, and so on. Parity is any pregnancy which was carried beyond the age of viability, irrespective of the outcome. The age of viability currently is 24 weeks, but with the advances in neonates, they are hoping to bring it down to 22 weeks. So any pregnancy which has gone beyond 24 weeks will be a Paris delivery. So if somebody had 3 kids, they will be para 3. If somebody had 1 child, they'll be para 1. Now, there is an interesting fact that, like, this is always a bit of a contentious issue when medics talk about parity and the midwives talk about parity. So if a woman has delivered twins, midwives will always say para 2, when actually she is only para 1, and in bracket you will write twins, because parity is an event rather than the outcome of that pregnancy. If someone is pregnant for the first time, it will be primigravida. Okay, so it's exactly what I said just now, that it is an event. So even if twins are delivered, it will be para 1 and not para 2. You'll always check the last menstrual period. Always check if she conceived naturally or after fertility treatment, again because that has a bearing on their management. Any issues in early pregnancy period, any history, family history of genetic conditions in both partners. If they had multiple pregnancies in the past, more than one pregnancy in the past, you will always check the outcomes of their previous pregnancy, whether it was a miscarriage or a termination, if any complications or issues during those pregnancies, if they had a vaginal delivery, was it term, preterm, spontaneous vaginal, or instrumental, if they had a cesarean section, was it term, preterm, before labor or during labor, and with the details as well as any associated complications. You will always request some basic bloods like full blood count. So you are aware that if the patient is anemic or not. If they're anemic, you can always start them on iron supplements. So their hemoglobin is built up by the time they're ready for delivery. You'll also do infection screens such as rubella, Hep B, Hep C, HIV, and syphilis. The dating scan is offered around 12 weeks. We also offer non-invasive prenatal testing for genetic abnormalities, that's called NIPT. Then they have anomaly scan at 20 weeks. Further scan and reviews are based upon their clinical need. So it is important to identify while you are taking the history that if the pregnancy is going to be a low risk, medium risk, or a high risk pregnancy, and based upon that, you will manage their pregnancy. So if they're a low risk pregnancy, at least in the UK, they will be seen mostly by community midwives and they will come to the hospital only if there is a problem. If it is a medium risk, then you will arrange some extra scans from 24 weeks onwards. Either they could be 4 weekly or 2 weekly, depending on the clinical need. If they are high risk patients, such as any medical issues or surgical issues, then that requires multidisciplinary team assessment, and the team will come up with a management plan, and that plan will be disseminated and will be available to check on the delivery suite for everyone looking after the patients. Thank you.